Well, hello everybody. Welcome 2018. We're started here. First bunch of thank yous to everybody, Troy and Chris Marchand and Jordan Friend and of course Dr. Evan Klass for making the ECHO program available and actually do a lot of the work behind the scenes that many people don't get to see, but there's a whole bunch of work that goes on. Also, University of Nevada School of Medicine, and I'm with Dr. Lewandowski. Today, Dr. Patterson is not available today, but he will be back for our next one. That's our regular panel team. Dr. Lewandowski has been a psychologist for over 30 years in his clinical experience and pain management and just a plethora of wisdom and all kinds of wonderful things. I specialize in substance use disorders and dependency, and I have a license in Nevada as well as in Minnesota. And so I want to thank you all for being here. We're going to go over a couple of things. One of the great things about the ECHO program is the flexibility and recognizing now that we have the AB 474 regulations that are coming up. We thought it would be prudent to touch on those first and then go into the alternatives for pain relief treatment and management. So we always open up in the beginning, get some introductions, as well as find out if there's anything that you need help staffing with, or any complicated cases, or anything that is on your mind that you'd like to utilize the whole group for, because we have all of the wisdom out in the community who are piped in, and we want to be able to tap into everybody's experiences to provide optimal health care throughout. So let's start off. We have, well, there's Dr. Cole up in the corner there.
Good morning, Barry.
Hey, good morning, everybody. Happy New Year. I'm sitting with my grandson. If you hear him screaming,
Wonderful.
Oh, he's good to have you, Dr. Cole.
I got to early how to be a pain specialist.
Say again?
I have to teach him early how to be a pain specialist. When we all become old people, no one's going to be prescribing after goes through.
That's right.
Okay, who else?
Linda Garrett.
Hi, everybody. I'm Linda Garrett. I'm the Lycon Risk Manager. One of my concerns with AB 474 is patient abandonment. I've been, for the last year, trying to convince our doctors that you can't just quit patients midstream. And I'm interested in knowing what kind of support we can give our doctors, primary care providers especially, to continue to treat their patients and do it in a medically appropriate way. So thank you.
Very, very good point.
Yeah.
Very good point. I also see that as an emerging concern. What's going to happen to a lot of folks that have legitimate persistent pain that are just kind of let go.
Right.
Yeah.
I think physicians are angry that the legislature is telling them how to practice medicine, and that anger is being kind of dumped off onto their patients.
Yeah.
Sure.
Yeah.
You bet.
Yep.
Penny Huss.
Hi, nurse practitioner out in Lovelock, Nevada.
Hello.
Good morning.
Welcome.
Good morning.
And Alan.
Hi, I'm Alan Fisk. I'm in Elko. I just am here for the technical support.
Wonderful. Good to see you.
And who do we have from the Reno Sparks Tribal Health Clinic joining us today? Just a second, let me take you off mute.
Oh, that is Dr. Noble.
Wonderful.
Yay, Dr. Noble. He is our medical director over at the Reno Sparks Indian Colony. Thank you so much.
We're having audio issues. I can't get you guys unmuted for some reason. But
Uh-oh.
And Dr. Postman?
Yes, good morning. When you get to it, I have a couple of questions from the presentation 2 weeks ago regarding sleep.
Okay?
Okay, absolutely.
Thank you.
And Tony, I'm not sure if we have audio for you this morning. Make sure that you click the join audio in the lower left corner of the Zoom screen.
Hi, I'm actually on phone.
Okay.
Bottom of the screen, and I am the CEO at South Lyon, and have enjoyed Linda's counsel for many years, so I'm thankful for that. While I echo Linda's concerns, I'm also having one of the requirements of AB 474 is after 90 days, the addiction assessment. And while I can find some, a lot that point to alcohol specific, I am having a really hard time finding a reviewed or an accepted, peer-reviewed assessment for the opioid addiction. And if there's anyone out there that might have a sample or a recommendation, I would really appreciate it.
Are you looking for an evaluation?
It's the in AB 474, after a 90-day prescription, then it's requiring that the providers perform, and it looks like an addiction assessment. So and as I said, I can find one specifically, with alcohol. I'm having a really hard time finding one that I feel meets the requirement that is more the opioid related or the drug related.
Well, there are certainly a couple, and we can certainly talk about that. The opioid risk tool from Dr. Lynn Webster is one that I know is being used to meet that requirement. The SOAP-R is another. So we'll certainly talk about that, and maybe where you can get some references and some of the companies that are providing those for physicians to use kind of online. So we're happy to talk about that.
Well, this is unique from the risk tool that you use on the initial prescription. It's the one after 90 days. So absolutely, I appreciate all the help I can get. Thank you so much.
We'll do our best.
And Tyson, you want to introduce yourself?
Yeah, I'm Tyson McBride, out in Lovelock, just a physician assistant, and enjoy watching these. And so far, I have no questions yet.
Hang in there. Good to have you.
Welcome.
Dr. Van Gilder?
Oops. Good morning.
Good
How are
morning.
you? Sorry. Late start. Dr. Van Gilder out in Lovelock, Nevada. And as always, I appreciate your guys' assistance. Thank you.
And William B. Ryrie, it looks like we have Dr. Christensen with us this morning, but your video is frozen. It seems like the audio is working fine though. Dr. Christensen, are you there? Maybe not. Okay. Becky?
Hi, Becky Bailey from Nevada Rural Hospital Partners. Can I ask you to repeat the name of that assessment tool you mentioned just a minute ago?
Yeah, the opioid risk tool. It's the acronym ORT, and it's Dr. Lynn Webster. He's right our next door neighbor here in Utah. He developed that test. It's peer reviewed. It meets, I think, what the intent was of the law of coming up with the scientifically derived assessment device for opiate issues. And the same with the SOAP, which is, I believe, the subjective opioid assessment. I can't remember the rest of the acronym, but that's another instrument that I think meets the state's requirements for peer review scientific.
So there's actually a link to that one from the state's website, and
yes,
are going to put a lot of the resources on our own website. And so, Tony, for your knowledge, it takes a couple of clicks to get to this one, but I'll download the tool and put it right on our website and send it out to everyone.
Thank you. That's wonderful.
We're just doing introductions. Elle Broughton, can you introduce yourself, please?
Yeah, can you hear me?
Absolutely.
All right. Yeah, clinical psychologist here at Community Health Alliance doing integrated behavioral health.
Welcome.
Welcome,
Thank you.
DHA. Good to have you.
Chris?
Chris Marchand, director here at Echo, Nevada.
And Pete Rogers, I don't believe we have audio, but you are another social worker
Wonderful.
at the Community Health Alliance.
Good, good.
We have someone signed on. Their screen name is just a period, and I don't know if we have audio for you either. If you could send your name in via the chat, that would be great. C. Guerrero. Are you there? Lori Sportsoff. Maybe no audio for Lori this morning. And Andrell.
This is Lisa Andre. I'm from Humboldt General Hospital Quality Services Director.
Great. Thanks so much. Glad to have you joining us.
Okay. All right, let's get started. Again, thank you all. Okay, so while we're going through the slides, we're going to be talking about patient abandonment. We're going to touch on some sleep and post 90-day evaluation. With that in mind, feel free to jump in anytime, and especially if you have any insights into those three topics, or you have something, burning desire or something that comes up, please feel free to jump in, make this as interactive as possible. So we're going to start with the AB 474 compliance checklist. Okay, this looks kind of complicated. This is from the Nevada State Medical Association. This chart, this flow chart, is available, and we'll send out the link here. And what it does is it goes through really nicely a quick screen tool to give you an idea of the flow of everything that needs to happen for the initial prescribing for controlled substances. Troy, can you back it up just a little bit? There we go. Okay, see the blue? Start at the upper left-hand corner right there. That's where we're starting. Now just follow that around. Look at the little hand go all the way over, down, across, up, and there's your gold bar. So that's the game. There's two areas here that say it doesn't apply and you can prescribe according to standard of care. So primarily, you're looking at these controlled substances going through these the blue little steps, if you will. So are you prescribing a controlled substance? Number one, check the PMP. Evaluate risk factors. Is the prescription for pain? This is the other exits thing. If it's not for pain, you go straight to the legally valid prescription. If it is for pain, then we go down, establish a bona fide partner or provider-patient relationship, establish the primary diagnosis and treatment plan, consider alternatives to controlled substances and document in medical record, evaluate HERR or medical history, physical examination, obtain medical records, risk of abuse, document in the medical record, good faith effort to obtain records, obtain informed consent, then identify patient-specific limitations for acute pain, that's 14-day maximum. For opioid naive, no more than 90 morphine milligram equivalents, and for 30 days or more, complete a prescription medication agreement, which we'll be showing you all of these agreements and contracts. They're already available on the state website too. Then you're ready to prescribe. Then you go with the complete a legally valid prescription where you need the patient's date of birth, the ICD-10 diagnosis, minimum number of days for patient consumption, and prescriber's legal name and DEA number. Before we went into this flow chart, I was talking with Dr. Lewandowski, and he has a really nice way of visualizing how to categorize two different types of patients. For the ones that need the narcotic or the controlled substance, and then the other one. So I'll turn this over.
Yeah, we were just chatting before we started. I imagine this as having two buckets. It's all under the heading of controlled substances, and one bucket would be for those controlled substances that don't have anything to do with pain. And you can see some of the steps that are required there. It's fewer steps in this model. And then those controlled substances that are used for pain management, which requires all the rest, a more in-depth process. So the thing that I think is important to realize is that it's for all controlled substances. This new AB 474 addresses all of those. I think it's schedules 2, 3, and 4. So that was helpful for me to kind of conceptualize how they fall into two different major categories. So.
Sounds good. Any questions with the flow chart? Okay. If they come up, just let us know. Okay, so then the next few slides we're going to look at before writing the initial prescription. We're looking at a bona fide relationship with the patient. Have I established the primary diagnosis, and what is the diagnosis? How do you set up the diagnosis? Is anybody setting up diagnosis now? Okay. Have I conducted a check with the patient's prescription history with the PMP? What's the history? Have I documented this review of the PMP and patient chart? Have I discussed a non-opioid treatment with the patient? Why was the non-opioid treatment not prescribed? Is there a reason to believe that the patient is not using the controlled substance as prescribed, or is diverting the controlled substance for use by another person? Has the previously prescribed controlled substance had the expected effect on the symptoms of the patient? Is there a reason to believe that the patient is using other drugs, including without limitation alcohol, controlled substances listed in Schedule 1, or prescription drugs that may interact negatively with the controlled substance prescribed by the practitioner or have not been prescribed by me? You getting the picture here? That's a lot of work before we're prescribing this stuff. How are you going to do that in 7 minutes? This is where the team approach comes in. This is where you need, when you're looking at someone who is before they're being prescribed, you want to be able to go through all of this, put checks in the box, and make sure that this is the appropriate medication, appropriate timeline, and then we're also looking at what is the goal, really, and what's the exit strategy. So if we keep those two things in mind and have another team member who's able to go through all of this, all of these criteria before setting up the person with an opioid, everybody will be on the same page, and then you can go and see more patients. Does all that make sense?
I have a question.
Yes, please.
Any advice on how to deal with patients that attempt to refill early?
Yes, that can come in the medication agreement, and the answer is no. If your dog eats your prescription, sorry. If you're shopping around, or if you have multiple prescriptions, it doesn't look like it's going to work again. And so that's part of the patient medication agreement, that everybody stays on the same page. And that's the whole idea. It's to stop diversion, it's to stop overusing, it's to stop putting people at risk for these narcotics.
Question here from Dr. Cole. Marijuana is a Schedule 1 drug. Will anyone prescribe any other controlled substance if the patient is lawfully using marijuana?
Okay, let's go back. Yeah. Okay, in Prescription medication agreement must include goals of treatment. There's our goal. Consent to testing to monitor use. So drug screens. Requirements that controlled substance is only taken as prescribed. Prohibition or prohibit sharing. Requirement that the patient informs the doctor of other controlled substance prescription taken. And there it is, use of alcohol and or cannabinoids. Here's the thing with marijuana and THC. It's under a huge umbrella. The stuff that we were smoking or 20, 30 years ago was being smoked where it took half a garbage bag of Mexican ragweed to catch a headache is no longer available. The stuff that's out there right now is a lot stronger. And so we're going from 12, 15% THC up to 95% THC in dabs. And so you have to find out what is in the person's system and then find out also what the strength of that THC is. And so, yeah, we're gonna have to know what's that, you know, and when we're looking at alcohol, just look at all of this stuff as substances. Take everything else out of the equation. But I have a lady who did not have a problem at all getting off of benzodiazepines. It's like, wow, how did you do that? She used it because she couldn't sleep and she was feeling a little anxious at night. She was only drinking 4 glasses of wine before she went to bed. So to the receptor system, you think of benzodiazepines as powdered alcohol. So she was just substituting one for the other. Then the important thing is you figure out what is going on in the person's system, and that's where another team approach comes in, because once I've worked with someone and we get the stuff out of their system, then we start playing whack-a-mole, because we have behaviors that are going to start coming up, and the addiction is going to change form from one area to another. So it's just keeping the puzzle going, looking for healthy, productive alternatives. And that's where the team approach comes in.
I'm curious, if I could, how many are on our seminar here today that don't have a problem prescribing an opiate if marijuana is also being acknowledged? And if you could speak to that and the rationale. Are there any providers who do both? Yeah.
So I have had a couple of patients who are not currently my patients now, and they were on marijuana just to kind of sleep. And in the past, I have addressed that with them. I know many providers will not do both. It's hard to really know, is this patient a reliable patient, but just discussing the risks of this is another substance that acts on your brain and it can impair you, and the risks of driving and operating other things are increased when you're using both of these together. I honestly am probably going to be changing my decision about allowing both based on all the current new information on our new marijuana that's out and the prevalence of it, but I don't know. We'll have to see.
The difficult thing with marijuana, unless it's Marinol, nobody talks about Marinol anymore. It's been out for 20 years. That's THC. That's regulated by the FDA. It has consistency, potency, purity, dosing, directions. It has all that stuff. It has studies. Or if it's CBD, are you talking about Epidiolex? That's been out. That's GW Pharmaceuticals. These are all regulated by the FDA. Who regulates the marijuana coming out of the dispensaries?
No.
The Department of Taxation.
Right.
Kind of puts things into perspective there. What's the dosing? What's the potency, purity? How's it being fertilized? What are they smoking? What kind? What's the THC level? How can you keep it consistent? Does your insurance company reimburse you for it? What does the recheck look like if you go in for back pain? Does the bud tender do a range of motion test? Or do they just sell you the next little baggie that's up on the thing? What's the difference between medical marijuana and recreational marijuana? It's the label. Okay, so there is nothing really that I know of that I've come across with that shows marijuana is medicine. Unless you're talking about Marinol.
So that'll end up being an individual practice decision, I assume, and it sounds like you're maybe changing your perspective.
Well, it was a very limited population of patient that I would really even consider that, but I'm rethinking it. Could you speak to the CBD oils, because that's a huge thing I'm seeing right now, and what your feelings are on it?
Mine, there's 480 compounds in the marijuana plant. THC is actually the plant's natural pesticide. A bird or an animal will eat it, feel funny, and will avoid it, saying this is not good. It gives me an altered state of consciousness. Human beings can't get enough of it. It gets them there, right? CBD, I don't know. There's Epidiolex, and that's a CBD-based pharmaceutical that's regulated by the FDA. And there's things like Charlotte's Web and different CBDs available. I think they need to be studied more because I have people that I work with that marijuana actually promotes seizures in them.
Mm.
Again, what are you taking? How are you taking it? Are you smoking it? That's a completely different system than if you're eating it. If you're eating it, it's got to be metabolized. If you're taking it in pill form, it's got to be metabolized. Once it's being metabolized, you're along for the ride. If you're smoking it and you get a little bit too high, you can always put that out, kind of control it. But once those receptors are impacted, depends on how you're taking it, what you're taking. It's between the moon and whale droppings what the truth is with this. And that's the problem. It's a moving target.
Hey, this is Barry again.
Yes.
I threw that question up just to keep us focused on the reality that we now live in Nevada with California next to us, where you can go in now as an adult and purchase any amount of marijuana, up to the statutory limits. But I've crossed this bridge before when I practiced at Kaiser in Honolulu, and we had a medical marijuana law to let people walk around with 4 ounces of marijuana in their possession, which is a big bag of marijuana if you think about what 4 ounces looks like. The reality is we prescribe under federal authority. Marijuana is a C1. I don't see how you can ever write a C2, 3, or 4 when they've already broken federal law and your ability to prescribe controlled substances is granted only by the federal government. Yeah, in Nevada, we get the extra card, but you can't even get that card if you don't already have a DEA certificate. So to me, the absolute line in the sand is the DEA, which says, you can't do C1 drugs in the United States. Who cares what the state of Nevada thinks? Now, on the flip of that, remember a couple of years ago, it came out in JAMA that in states that have medical marijuana laws, that the opioid overdose rate was actually lower. So people stopped presumably dropping benzos with opioids. Yeah, they did smoke marijuana with their opioids, but it was a less fatal outcome because you don't get respiratory depression from marijuana. So I'm going back now to the way I've had to face this. I tell patients there's 2 doors, left, right. The left door, I prescribe opioids. The right door, you do whatever you want with marijuana. Both may actually be clinically effective, but under my prescribing authority, you can't do both at once. You choose. And I mean, to me, that is the ultimate informed consent. You choose. Here's the information. It's your decision to your risk. Anybody else going to take that approach?
Well, we're starting to see more and more issues with marijuana use, driving under the influence. Things will start popping up. I'd always take a conservative approach, wait for studies to come out wait for things to kind of bubble up. It looks like the pendulum's going to be swinging. And who remembers candy cigarettes? Are cigarettes good for us? Remember when smoking was used for asthma? Who remembers THC infused gummy bears? What are we doing?
But I think it's an interesting point that Dr. Cole brings up. It may come down to an individual's decision. Both Paul and I are blessed in some respect. We don't have the power of writing a script. So that's not an issue we're going to be facing, but it will be an issue that you have to face. And, you know, looking at the federal laws versus state laws and the implication it has for your license and your practice is huge. So I don't, you know, I feel for the position you're in. Add to that what was said earlier in the introductions with the comment about what are we going to do with the number of these patients that will be, in effect, abandoned from their opiates and their doctors saying you need to go see a pain specialist. But those official pain specialists are so overbooked that it's 3 months to get in. What's going to happen? I think it's going to be interesting to see where people will turn, and they most likely will go to marijuana as an alternative, as a guess. But I don't know. Any other thoughts out there?
Yeah, they'll go to the emergency rooms.
Yeah.
That's where they always go in an emergency. They go to the emergency rooms. And I suspect our ER colleagues are not going to be happy very quickly.
Yeah. Interestingly, yeah. And if I read the law, AB 474 correctly, emergency room docs and hospitals in urgent care do not, the AB 474 is not applicable, so they don't have to do an opiate risk at that moment, if I'm reading that correctly. Is that your understanding out there also? So they're exempt from what I've read. So, but that's where the funnel is going to go. It'll be in the ER room. Yeah.
It will. And keep in mind too, physicians can't prescribe marijuana. Pharmacies don't carry marijuana. Insurance companies don't cover the financial part of marijuana. So if you're sticking to prescriptions as a physician, you can recommend, but you can't write a prescription for it. Okay, so we have, before I can write an initial prescription, here are all the checks. Before I can write an initial prescription, I must identify, has the patient increased his or her dose of the controlled substance without authorization from the practitioner? Has the patient been reluctant to stop using controlled substances or has requested or demanded a controlled substance that is likely to be abused or cause dependency or addiction? Has the patient been reluctant to cooperate with any examination, analysis, or test recommended by the practitioner? Does the patient have a history of substance abuse? Is there any major change in the health of the patient, including without limitations, pregnancy and/or diagnosis concerning the mental health of the patient that would affect the medical appropriateness of prescribing the controlled substance for the patient? Is there any other evidence that the patient is chronically using opioids, misusing, abusing, illegally using, or addicted to any of the drugs or failing to comply with the instructions of the practitioner concerning the use of the controlled substance? Is there any other factor that the practitioner determines is necessary to make an informed professional judgment concerning the medical appropriateness of the prescription? So again, another reason to have somebody, before they see the physician, actually go through all of these criteria. Another thing is, you know, when I work with somebody in substance use or substance dependence, whether it's physiological or psychological or addiction, the idea is they're not a bad person. The idea is to get them off of whatever the substance is and not label it, because it's all, if we introduce anything to our body or our brain consistently, our body and brain will become accustomed to it. And so the idea is to have them be less of a hostage to whatever the substance is. And so when we're looking at this stuff, when we're looking at marijuana, where we're looking at opioids, we're looking at benzodiazepines, we're looking at alcohol. It's all kind of the same stuff. A lot of the treatment is the same. It's getting to know where that person wants to go and how to move them forward and progress in the stages of change. And they get to see that through payoffs. And here's the problem. If you're taking somebody off of opioids that's been on them for 20 years, and all of a sudden we're changing the thought process and exposing those nerves that have been covered up for so long that the body has become used to it, the pain signals haven't stopped, they've actually been amplified. Now we rip that off, we don't give them the security blanket or the go-to by taking away their substances. That requires the team effort. That requires getting into the brain and helping them walk out of the forest that it took them 20 years to walk into. And that's a complete change of thought process, lifestyle, and a lot of times environment. So when we're doing this wraparound service, we're looking at how can somebody screen all of this stuff in a time-sensitive way that will validate your time and take care of that patient. Here's another thing for the initial prescription. What type of prescription do I propose writing? What's the duration? Is the prescription for no more than 14 days? Have I considered the 90 morphine milligram equivalent limit for opioid naive patients? Or is there just a blanket statement out there that says if you're going in for surgery, this is what you're going to be exposed to? I've completed the patient risk assessment. The patient has completed the informed consent. Here's the patient risk assessment.
Can I go back one?
Yep, go.
If you look at the 5th point there, I've completed an assessment of the mental health and risk of abuse, whatnot. The one word I'd like to emphasize in that I think is really critical is the word "and." If you look at mental health and risk of abuse depends, that would suggest that that is potentially a 2-step process. So just measuring opiate risk measures the second part of that statement. It's not necessarily measuring mental health. So it may be that you need to do 2 assessments to fully meet the criteria of completing this assessment. And I just raised that point because I consulted an attorney, and attorneys love words, and they dissect everything. And that word jumped out, the word "and," meaning in addition to. So those could be perceived as 2 separate things. I'm not sure the writers of the law intended that, but when it comes down to legal matters, that word "and" may make a huge difference. So my encouragement to all of us out there would be to take a look at finding and at least covering both the mental health as a separate issue from dependency, addiction, and abuse. And so I think that's it. And if I could make one other comment, I believe AB 474 may turn out to be the mental health bill in Nevada because, let me propose this. If you're being asked to identify risk and you're identifying risk, and in this case, identify some mental health issues and potential opiate addiction issues, and you don't do anything about it, you're going to be liable. So you better have, I would encourage you all to consider ponying up or partnering as a team, as Paul has said a number of times, with some mental health people, whether it's addiction specialists, pain management psychologists, licensed clinical social workers, to be able to then make a referral for those needs, because you identify them by taking these steps. And now I think, again, from my attorney friends, it's increasing your potential liability. So I would just make that comment on this particular slide.
That's a great comment, and that's another point. I'm blessed to be working with really solid, competent, good psychiatrists, and we have clinical psychologists and mental or family practitioners. We just have a really strong team. And so usually if somebody is referred to me, we can do it a lot of times in-house. And when they're referred to me, I recognize that this is a package deal. If the person is dependent on opioids and we work on getting the person off of the opioids, then we have anxiety, depression, remorse, grief, all kinds of stuff that comes up. And it's almost, you can take a lot of this stuff on a timeline and say, now that the person is getting over this, or hey, person, this is what you have to expect. At this timeline, in this area, you're gonna get some insomnia. I'm gonna work through that with you. And you're gonna feel anxious, and you're gonna feel nervous, and you know what? You're gonna be snapping at people. And you know what? That's a good sign. That's healthy. I'm gonna work with you, letting you recognize what coping skills you can use while you're going through that symptom, because it's your body just adjusting, getting ready to get on that healthy path again without the substance.
So you work in a facility that has an interdisciplinary model under one roof.
I do.
And hospitals, of course, do too if you've got behavioral health departments. But I think the concern is for the primary care physician, the lone rangers that are out there. My advice would be to consider hooking up with some mental health agency or mental health group that you could make referrals to when you identify this risk.
And you do, and then also interview. Not everybody is created the same, and so you want to make sure that they have the same philosophy that you do, that you're on the same thought process, that you have a timeline set up, that you know what they're going to offer, which theories they work on, what are their methods, what are their just who are they? Because you get somebody who's a licensed alcohol and drug counselor, it doesn't mean that they all have the same thought processes or theories or philosophies.
Hey, this is Barry again. I just want to agitate one more time. Read the product insert, the PI for OxyContin, and know that it says risks are increased in patients with a personal or family history of substance abuse, including drug or alcohol abuse, or mental illness, e.g. major depression. And the reason I bring this up, this coming Sunday down in Vegas, Don Havens is going to be putting on a seminar with Joe Hardy, and the bottom line is one of their handouts is the Beck Depression Inventory. In other words, we now need to screen everybody for the possibility of major depression, since it's right in the PI for OxyContin. You better clear them of depression. You better also clear them for everything else. And remember, if you do chronic pain management, 50% of all of your patients will meet the criteria for what used to be called an Axis 2 personality disorder. And the only good news is 15% will be borderlines, the rest won't. Think about what that means.
Yes.
Dr. Cole.
Yes. Yeah.
Is your informed consent form?
Yeah, Don Havens sent 2 different informed consent forms to me. One is very different from the other because it's more about like making sure women don't conceive while on opioids, which is sort of interesting because if you take opioids appropriately, men will probably have a lower sperm count and women become anovulatory anyway. But, we now have to get into this whole idea of neonatal withdrawal syndrome. And then he sent another one of the informed consents that has sort of a different, more legalistic perspective. If you need to, you might want to reach out to Dawn to get these handouts because there is no room left for either Sunday or next Wednesday's conferences in Vegas. Touro University sold out immediately.
Yeah.
Whoa. A couple of other things. If you're looking down at the second to last point, if the controlled substance is an opioid, I've discussed with my practitioner the availability of an opioid antagonist without a prescription. And so we look at why would we need that? It's not to demonize opioids, but if somebody's everybody who takes opioids or is not going to be addicted to it. But a lot of people, especially elderly people, don't understand what's happening with the opioids. So if they have a flare-up and they take their Oxycontin and they have a little bit of wine and then they take another one, many of the overdoses happen accidentally. And so the opioid antagonist is available. It's over at Healh. You can get a couple of syringes for $25. And that's just to blast off those opioid receptors, get them the help that they need. It's not to say that everybody who's going to have an opioid is going to be taking this and using it or diverting it, but enough people have been doing that it's cause for this kind of action. If the patient returns after 30 days, then we have the prescription medication agreement. There's the prescription medication agreement. Patient agrees to test to monitor drug use when deemed medically necessary by the practitioner. Okay, so if somebody who comes in like clockwork, every month they're getting their 60 pills, their opioids, and they've been coming in for a year and a half, and they've never asked for more, they've never asked to be titrated down, and you decide to do a drug screen on them, and they don't have any opioids in their system. Something to think about. Patient agrees to take the controlled substance only as prescribed. The patient agrees that sharing medication with other person is prohibited. This is something that we get into with people and say, well, the doctor prescribed it, it's got to be good. And so I ran out of mine, so I went over to my neighbor. He has the same kind, and so we just share them. The patient agrees to inform the practitioner of any other controlled substances prescribed to or taken by the patient. You need to know what's in that person's system, whether the patient drinks alcohol or uses marijuana or other cannabinoid compound while using the controlled substance. And that's not to demonize marijuana either. The whole idea is you have to know what substances, regardless of the thought process behind it, what substance is in that person's system, and how are those substances interacting with each other? What is going on? How are they being metabolized? How is one impacting the other's metabolism? How much are they taking? How are they taking it?
And if I could add, I'd love to reinforce the idea that this is an agreement, not a contract, so it's not a legal issue. But with an agreement, this facilitates a conversation between the doctor and the patient, which is what really needs to happen. That the patient needs to realize that this is their pain management and they're playing a major role in it. It's not all up to the doctors. This is a mutual agreement, and it facilitates that conversation. And I think in that respect, this is a very helpful tool.
That is a really good tool. And then also screening tools where you can see and work with the patient to see their progress. Mm-hmm. So that they're part of the progress. They're excited for the results, seeing the measurements go down. They can see their health getting better. Okay, so that's the prescription medication agreement. You can read the rest of it. If the patient returns after 90 days, more criteria. Risk of abuse assessment. If the patient returns after 365 days, this was a push, it was 365 and not prescribing more than 365 days worth of medications, which sounds kind of obvious in the beginning, but if the person has used 365 days of medication in 8 months, then probably have an issue. Oh, I'm sorry, check the PMP. I've completed a check of the PMP every 90 days. And now we're getting into drugs, alcohol, and and Health. So are there any questions? Like Linda, when we were talking about the patient abandonment, does anybody have any solutions for the patient abandonment?
Could I also ask one other question? You mentioned a few minutes ago that you believe that the emergency room doctors are exempt from 474. I know there was discussion about hospice programs and emergency departments not having to follow 474, and I'm not aware of that. I just rechecked 474 and I can't find any exception for emergency departments.
Well, let me do a check while with some of my documents here. But like I said, I think that is an important distinction, certainly.
We will definitely look that up. You know, with the patient abandonment, that's where one of the things that kind of jumps out at me is the team approach. And so not letting the physician just be there out there alone. And that's one of the reasons for the ECHO program, is so that we can all discuss what are the best strategies for providing optimal care with the limited amount of time that you have, and all of these new regulations that are coming down. And these, like Dr. DeMuro was saying, this isn't a request, these are requirements. And so when we're looking at that, if you have a team approach, and like me, for example, I'm talking to, we have a release of information, so I can talk to the psychiatrist and let the psychiatrist know, while the patient also knows we're all working together and this is what we're working on. And then if relationship issues come up, then I go to my marriage and family therapist, or my professional counselor, and we also have medical and dental. We can bring the whole team together, and so I can see that person for an hour a time, for a week, every week, sometimes multiple times if I need to, for a temporary amount of time. I'm not going to grow old with them, but then I'm not going to spend 20 years going over the same thing, because that's showing that the cycle, the medication cycle, that's a medication management kind of cycle model.
If I could, I have a question and answer, kind of frequently asked questions for AB 474. Be happy to share this with you. It says, are hospital and standalone emergency departments required to comply with the requirements of AB 474? Let me read to you what it says here. It says, AB 474 applies to all practice settings where controlled substances are prescribed or dispensed for pain. The requirements of AB 474 do not apply to medications ordered for administration to the patient on site, including in an emergency department or clinic or in a hospital. The citation is AB 474, sections 51 to 64. So I'd be happy to share. It's a document I have. It's AB 474, frequently asked questions.
However, if you're going to prescribe from the ER, or in our rural ERs, we actually dispense for weekends because we don't have a pharmacy here. If we're dispensing any for outpatient use or writing a prescription for outpatient use, we're required to still have them sign a consent. And that, we have actually started that in our ER this week. I was on in the ER. But that's a good distinction. You know, we don't have to have them do it while they're inpatient or while we're administering in the ER, but if we're writing for them to go home, they need to still have that.
It's a good point. So another informational, I think at 11 o'clock today, the Board of Medicine is having, there's a video conference, and they're talking about some of the law, or some of the, what would you call it, the consequences of not following this law. So I would invite you to take a look at that. It's a video that's going to be presented today, and I think we'll get you that citation. But they're talking about some of the consequences for docs who are, I guess, identified as not following this, with, I think, 5 different levels of sanctions. There are 5 different disciplinary responses as it sits right now, but it's still being discussed, I think, and that's part of what that video is about. So a lot is still emerging, and here we are on is it January the 3rd? So.
How about sleep? Does anybody have any suggestions for sleep for people who have? We have a Echo Sleep clinic that we've already gone through, and that's already been recorded and available. But does anybody have any suggestions for your patients with sleep issues?
No, we talk about sleep hygiene and give handouts for that and try to offer, teas and melatonin, and if there's significant other concerns for sleep, we try to get them evaluated for sleep studies.
Outstanding. Wasn't there a question about sleep earlier when we did interruptions?
Yeah, Dr. Postman.
Yes.
I think Rose brought it up.
From last time, Dr. Lewandowski, when you were talking about sleep.
Yes, sir.
And I don't believe you got into the area of blue light before sleep. I don't recall you mentioning that, did you?
No, we didn't. I didn't talk about that section of sleep treatment.
Okay.
But certainly, the lumens, the light therapy is a very valuable and I think proven treatment for different kinds of sleep conditions. Certainly.
In the literature, there's a lot of information about avoiding computers, mobile phones, that sort of thing for about 3 hours before intended sleep. And also, it would be nice maybe to get a little bit more into that at some point if you have time. But also, it's interesting that I don't know about the other phones, but on iPhones, there is actually a setting called night shift where you can change the color pattern. You can adjust when you want it. The default is to come on at 7 p.m. to go off at 7 a.m., where you shift the light from blue light to warmer tones, and the person operating the phone can actually control not only the on-off times from the default, but they also can change the brightness intensity. So anyway, I thought maybe at some point in the future, if you ever get back to talking about sleep, it might be an interesting thing to include.
It's a great point. A colleague of mine, Dr. Michael Lucia, has even taken that one step further. There's he's purchased a screen that he put over his iPhone and even his computer that also dampens some of the damaging light rays. And he has said he's found that to be helpful too. So excellent topic, and I think
I know Michael and I were working together some years ago about because of his interest in allergy, and of course I'm an allergist. But my understanding is that might be a nice thing for your computer, but not necessary for an iPhone. It's really not necessary because the feature is essentially built in.
Interesting.
Yeah.
Yeah. Which means that with one click, you can implement that therapy.
You not only can implement it, but as I said, you can control the on-off time and the intensity of brightness, or at least the warmth.
Very good point.
You control both the intensity of brightness and the warmth of the screen.
Good. And I also think I have a book for you from that talk. You answered that question on Malin-Potty score correctly. So, I'm sorry. So, okay.
All right, just a minute after 9 o'clock now. Any other questions for our panel today?
Well, thank you all for being here. We're going to be doing this again next couple of weeks.
January 17th, yep.
17th, okie dokie. If you need anything, please don't hesitate to contact us. My contact information is in the PowerPoint, and Dr. Lewandowski is always here too.
Yeah, thank you guys.
Okay, thank you.
Couple weeks.
Thank you so much.